restricted. Yeah, so that's still a lot of patients that visit my clinic. I need to see the patient and do the surgery every day.
Yeah. It is good. We are here at the Eye Bank Foundation. We are scheduling people. Yeah, it's. Let me just turn the sound off. We are live from YouTube as well, but I'm turning the sound from YouTube off. So, I don't think people are going to need to use YouTube. It's just there for the organization things. But we are getting ready, and 10 minutes we're going to start. And it's really an honor, Dr. Shima, to have you here. And I want to welcome also Dr. Vasco Bravo.
Good morning, Hudson. Good. Good morning, everybody. It's a pleasure being here with you.
Yeah, it's always a pleasure to be with you. And we are waiting for people to connect.
So, Harrison, can you see my voice well?
You see what?
Can you see my voice well?
Yeah, it's really good. Yeah.
Okay. Because I did not use a microphone. I'm so very concerned about my voice and sounds. About it, is okay?
Yeah, it's perfect.
It's great.
Okay, perfect.
I like using the microphone because it condensates the voice. It makes the sound a little clearer. But these computers from today, especially these Mac things, they are very well made. So it runs well with their built-in microphones. So Rafael, is everything okay? The connection here is good. And Rafael is our moderator. He's been with us in all Retinawesome meetings. This is the third one. And also Dr. Edwards from the Eye Bank Foundation. He's probably around. Edwards, are you in? Você tá aí, Edwards? He's coming. He's the moderator from Brazilian language, the Portuguese, I mean. And Dr. Rodrigo Pegado is there too. How are you doing?
Hello everyone.
How is Rio de Janeiro?
Hello, my friend. I like your microphone.
Yeah, thanks. Yeah,
it's very well.
Makes the everything clearer, and
yeah, it's better. It's much better. Yeah. Our audio.
And Rafael.
Right.
Are you getting the speakers as co-hosts?
Yeah, I cannot do that. You have to do it yourself because you are the host.
Okay. So I guess almost everybody here is into co-host. Dr. Robert Deveni is there coming. Good morning, Dr. Deveni. Dr. Deveni was my professor in the University of Toronto, together with Dr. Wai-Ching Lam, into my retinal fellowship.
Nice to see you.
Hi, Dr. Deveni. It's such a pleasure to see you again.
Likewise. Thanks for organizing this. This is great.
Yeah, I was trying to reduce a little bit of your video, but it is so amazing that I could not reduce it much because it's so good, you know? Every detail is important there. And so it was pretty good. And we are having here, Dr. Deveni, also Rafael Arantes is the co-host and also moderator. And anything you guys need in terms of technical things or problems, you just announce and talk to him or talk even here. And we are live on YouTube as well. And we're going to take care of it.
That's great.
So, Rafael, please tell me if the speakers are in so that I have to put them into co-hosts like Dr. Natarajan just entered. Hi, Dr. Natarajan, how are you doing? It's evening already in India.
Nice to see you, Yusuke.
Hi. I see you.
Yeah, long time.
Yeah, long no see. How's it going?
Yeah, I think you and me are the one maximum traveling now in the Zoom.
Yeah, that's very good. Well,
that's true. The last time I saw you guys was in the World Retina Congress in Fort Lauderdale.
Yes.
Yeah.
It's some time.
I think that Dr. Sethi is on. I'm not sure if it is Dr. Vaibhav Sethi.
Vaibhav Sethi, yeah, from India. Vaibhav Sethi.
Aaron Sethi. I don't know if.
No, this is.
Yeah. Vaibhav Sethi is on.
Oh, okay. So I'll make him co-host as well. Welcome, Vaibhav Sethi.
Thank you so much.
Hi, Vaibhav.
Hello.
Yeah.
Hello. I guess Dr. Who is that? Dr. Martinez? She's in?
No, not yet.
Dr. Martinez asked me to be the first speaker, and after Dr. Martinez, we're going to go on. And how about Dr. Oshima? Do you want to be the? Do you want to give your keynote lectures after Dr. Martinez?
Dr. Yukihiro and André Jucá are on.
André Jucá is already a co-host. Okay. Good morning, André Jucá. Ça va bien avec toi?
Good morning, everybody. Très bien, merci, mon ami.
Dr. Jucá, he trained in France, so he speaks good French.
That's great. Real French, not Canadian French.
In Canada, you know, we used to speak some French, but not so much, usually English. Dr. Yonekawa is just coming in.
Hi, good morning, everybody.
How is everything?
Very good. Thank you.
Yeah. How is the weather likewise in your area?
Oh, weather, pretty good. We've been enjoying, there are a lot of fireflies in our area. And so the kids spend all night catching fireflies. So that's been our new thing these days.
Yeah, that's great. Nice having you here. And it's always a pleasure.
It's an honor.
And I am a #1 fan of Wills Eye Institute. And many professors of mine from Brazil, they trained in Wills Eye during my residency time. You know?
Oh, that's great.
It's a very good service, and I think you have many branches, no?
Many branches, many offices throughout the 3 states, New Jersey, Delaware, and of course, Pennsylvania.
Pennsylvania. Okay. Dr. Rafael, am I missing anybody for the co-host here?
Gustavo Running just entered.
Gustavo.
Morning, everyone. Sorry for the delay. How are you?
Hi, good. Gustavo. How are you doing?
Fine. Konbanwa Nihon.
Konbanwa. How's it going? Hi, long time no see. How are you?
Excellent. Genki desu ka?
Genki desu yo.
We are going to have Gustavo speak for Dr. Lucan Michev, and his father has died 2 days ago, and it was unfortunate that he cannot participate because his father just passed away. Is he okay now, Gustavo? He's better?
Yes, I talked to him this morning early, so he gave me the instructions to present his case. Actually, it's a nice case, and he's okay. His father had a melanoma, and they were waiting for that. But you know, beloved people, you always want to be for always, forever with us. That's life.
Yeah. Okay. I was telling Dr. Lam
it's
in
not
a
easy to.
previous email some time ago. I think Dr. Lam probably thought the meeting could be 10 p.m., but 10 p.m. in Japan. But in Hong Kong, it's 8 p.m. So we are about to start. I'll just try giving the WhatsApp call for Dr. Wai-Chim Lam to see whether he's going to be ready for the meeting, because he might think it's a little late, but in Hong Kong, that's going to be 8 p.m. right now. So let me see if I catch him, but if he doesn't show up right now, he's going to catch with us in a few minutes time, I guess. So Dr. Deveni, are you doing many Argus cases in Toronto?
Well, we did a lot. We did it, I think, more than anywhere in North America. I did 18, but now the company's basically finished. You know, they've had all kinds of financial problems, and they've essentially gone bankrupt, from what I can tell, as have virtually every company that's making artificial implants these days. I think perhaps with the exception of Pixium, but I'm not quite sure where they are. I don't know if anyone on the panel knows, but it really is a classic situation of an orphan disease, and the economics of it made it very difficult for these companies.
Yeah, I understand. And I was listening to Fernando Arevalo talk some years ago here in Brazil, and he was telling that the Argus 2 would be a lot better with the implant itself. Would need more wire things or more these small screws things, but I don't know whether that went on or not. Maybe not, because especially now, these COVID times, things are a little difficult, I guess. So people are getting in, and Rafael, can you see any more speakers so that I can make the co-host?
No, not for now.
Not for now, and I don't see yet Dr. Maria Martinez Castellanos. So I think we should start the meeting in the right time, and then I will have Dr. If she doesn't show up in time, have Dr. Oshima start his talk as well. So may I share my screen now, Dr. Rafael?
Yeah.
Okay. So let me get it. Should I share down below computer sound, optimize screen, or not? Just leave it like that. The internet here is good, it's okay.
Leave it like that. Leave it like that.
Okay. Looks okay. Can you see my screen?
Yeah.
So I will start this video over here.
especially my professors, Dr. Wai-Ching Lam and Dr. Divini from my Retinal Fellowship here in Toronto, Canada. This day, consideration for accepting to be the keynote speaker for this event. This event is on the vaccine in Brazil and the immunity foundation. Distinguished doctors, good morning, everyone. I would like to welcome the participants in the June20 study and discuss the challenge in retinal cases in vitreoretinal surgery. As chairman, on behalf of the Goiás Eye Foundation of Brazil, I greet all the participants. We thank and greet the Professor Dr. Nakamura for his important work in this international retinal event. Also, we welcome all the doctors who participate in this event from Brazil, India, Mexico, Arabia, United States, Canada, Bulgaria, Bolivia, and other countries. Taking this opportunity to learn, discuss, and know more about this wonderful world of retina. Have a good meeting and lots of productive discussion. An excellent day. Thank you very much. Are myself, Professor Nakamura, my professor, Wai-Ching Lam from Hong Kong, Andreas from Brazil, Seti from India, Michel from Bulgaria, Gustavo Hunter from Brazil, Marcelo Morelos Sassamoto from Bolivia, Maria Martinez Castellanos from Mexico, Oscar Bravo from Brazil, Yoshihiro Yanakawa from the United States of America, my retinal partner in Toronto, Sar Wahid from Saudi Arabia, Oshima from Japan, Professor S. Natajan from India, Rodrigo Schwartz Pegado from Brazil, my Professor Rob Divini from Canada, and Rafael Arantes from Brazil.
Yeah, it's a great pleasure, and we have here Dr. Yuzuki Oshima. And I said it's a really an honor to have you here, and I would like you, Dr. Oshima, to know if you could say some words for our participants, since after your words in this opening event, I will start playing your great videos. I became amazed with your videos. They are really, really great. Welcome again.
Hi. Here right now, right now in Japan, it's 9 p.m. Good evening, everybody. So it's my great honor and pleasure to be invited to participate in a great meeting. So right in Japan, as you know, we also have the COVID-19 problem. Hatun, can you hear me?
Sure. Let me just.
Yeah, but you know, we are very lucky. We don't have so many severe cases with infected with COVID-19. So just a couple days ago, the government just released quarantine, a very severe quarantine, so we can do much more. Go back to the normal, almost nearly the normal daily life. So that means so many patients still visit my clinic. Also do a lot of surgery as previously, you know. So let's just to start our video, okay?
Okay.
Today I will show you two cases. The one is a young boy.
You want to share your cases here?
Yeah, can you run this video?
Yes, I have the video right here.
Yeah, one case is a young cold patient. Another one is very standardized, you know, the well-known dropped crusting lens, how to manage the intrascleral suture, intrascleral fixation. I will show here.
Yeah, just share the screen now. Yeah, I think it's going to start.
All right. Can you can I run the video?
Yeah, it's just starting now. So,
which one you will show?
Yeah, we are going to show first the this one.
Oh, this is a cold case. This is a junior high school student. It's a baseball player. He had long-standing colds and getting worse and worse, even though several times session the laser applied another doctor, and they consult me for the surgery. You can see here the patient has thylacine attachment with somewhat contraction from the membrane right here. So I do the lens-sparing vitrectomy to remove the membrane, release traction, and then perform the island peeling. It is stained with BBG, and you can use forceps to remove the island. And the most severe problem at the peripheral area, it's a very big, very large angioma localized, just strongly adherent to the peripheral area. So not only use the forceps, I need to use the scissors to separate the membrane and gently, but unfortunately, I still, I cannot avoid to make the still region breaks. In this case, in young patients, it's very, very important to how to release the peripheral traction and remove the vitreous as much as you can. But even though in the case you can did it, but still we will encounter some contraction. So in this case, I performed not only the vitrectomy, I also performed the encircling bond to releasing the peripheral contraction. Can you run the video again?
Yeah, just a minute.
And because this is the case, basically it's detachment due to the thylacine agitation. So the key point is not make the breaks during the surgery, especially at the posterior pole. So I just do the membrane peeling with vitreoretinal removal. I don't like to make any intentional hole to aspirate the subretinal fluid, because it can be, once you can release all the traction and stabilize the activity of the macro aneurysm, you can make the spontaneous absorption of the subretinal fluid gently after surgery. The only one concern about the young patient is, it's peripheral contraction. So that I like to do not only the between alone in such a case, if there is some proliferation on the peripheral area, I prefer to do the vitreobacro combined with vitrectomy.
Just a minute, let me get your video again. Just
right.
Escape it from the program here. Just a second.
And I can tell you that patient initially visit our clinic, the visual acuity is 20/400, very severe. And right now, just 6 months after the surgery, right now, most of the sulfate already disappeared, and the visual acuity recovered to 20/80. It's the most of the activity already stabilized. So this patient can go back to school and play the baseball as a baseball player and do very well.
Dr. Raphael, can you help me here to see his video? Just a second.
Just share your screen because you're not sharing it.
Yeah. The screen, just a moment. Let me go back there. Sorry for that, Oshima.
So otherwise, can I run the video here?
Yeah, I think I have here. Yeah, just got it. It was hidden. Yeah, it's perfect. Just a second. Let me share it again. Okay, that's it. Sorry about that. Okay, you could go on.
Oh, let me see. I cannot catch up you. Or oh, here it is. Yeah, this is the show the very large membrane covered angiomer. So once I use the forceps to peeling off the membrane, and then need to use the scissors to separate the thickened membrane adherent to the angiomer. It's not easy to remove all of the angioma. Otherwise, we encounter very severe bleeding during the surgery. So I just release traction as much as possible I can do, use the cutter, scissors, and the forceps. But I still think that at the periphery, unfortunately, I made a very small, tiny breaks. So I decided to perform the buckle to support this area. Otherwise, even though it's very tiny breaks, because of contraction, may encounter the detachment after the surgery. So I also do the laser and combined with the cryo because they were down to the angioma. Here is the large of the breaks are here. So I do use the silicone sponge, make the buckle, a little bit wider buckle to support the peripheral area, and then also use the pinpoint laser to apply to the microaneurysm and the microaneurysm. And even in this case, most doctors prefer use the silicone oil maybe, but basically I love to use the gas because I like to prevent the subsilicone oil, the proliferation. So most of my case, if even it's a proliferative cases, I prefer to use this is the second case, I just still talk about the first case. I prefer use the gas for tamponade. So this is the second case. It's a dropped crystal lens. As you know, this is not a very hard lens. I can use the high-speed cutter. This is a 25 gauge and 10K variable cutter. The one key point is I use forceps to insert into the crystal lens. So I can hold it into vitreous cavity, use the cutter to remove the lens particles, just like the barbecue. We so-called the barbecue technique too. And then here I show you, this is the Yamane technique to make the intrascleral fixation of the lens. The key point is the forceps. This is also the max grip. I hold the haptics and insert it's a very thin inner wall, the 30 gauge needle, and guide the haptics into it. And just leave it as it in the vitreous cavity. Don't remove it to the outside too early. Just keep it in the eye and then hold another haptics and insert it into another needle and keep both inside the vitreous cavity. And the key point is rotated gently at the same time, and then you can guide it, the haptics outside of the eye. Because if you once you remove the one haptic first, it's not easy to insert the second one. So just like here, you loaded both haptics together and then control both the reinsert into the eye to control the centering, just like you here. And the advantage of this technique is no need to make any large peritomy. You can fix the lens, makes the very good centering, and adjust the depths and control the IOL refractive error. You can control that one at the same time.
In great cases, really, really great cases. And especially the two cases are great. And I want to have Dr. Diveni and Dr. Vaihapsethi to comment on your cases. Please, Dr. Diveni, what did you think about?
Here's some question about it. Do you prefer to do the vitrectomy primary? Yeah, in this case, of course, you can do the suture first and then perform vitrectomy. But if once you do the buccal first, it's not easy to perform the scroll indentation during vitrectomy. So in my case, most of my case, I remove the vitreous and the shaping periphery, and then at the end of the vitrectomy, I suture the buccal. Of course, you can do the mattress suture first, and then go to the vitrectomy, and then fix the buckle at the end of the vitrectomy. If you do the buckle first, it's not easy to perform the indentation. Yeah.
Okay. Beautiful cases, Dr. Shima. Thank you very much.
Yeah.
Now we have a question from André Juca. He's asking you which lens you're using for the Yaman fixation.
Yeah, this lens is Japanese made Santen IOL, but you can also use some other lens just like Archon or AIMO also released a 3-piece IOL. And the one key point is check the connecting point connection between the haptics and the optics, because one inserted, you need to remove it still a little bit tangent and stretch to the connecting point, haptics and optics. So if it's a weak one, you will be encountering to drop the haptic during the surgery. So most of the kids can do it. And we prefer use a large optics lens because they you can choose much longer total length of the IOL. So basically, my lens, the diameter is about 7 millimeter, and total length maybe around the 13 or 13.5 millimeter.
Okay. So, Dr. Robert Deveni, do you have any comments regarding these surgeries?
I think the Coates case was great. What I've also done, I find sometimes, as you said, the subretinal fluid can take a long time to dissipate, only because they're often chronic. It's very viscous. I've found that they often even have these crystalline proteinaceous subretinal deposits, and it is essential to avoid retinal tears, obviously. And what I've done on a few occasions with good success, I try and avoid buckles. I hate doing buckles ever. I can't remember when I've last done one except on an Argus. But what I've done is I've done a vitrectomy and then inject intravitreal perfluorocarbon and then do a scleral cut down as if I'm doing a buckle. So not to create a retinotomy to drain the subretinal fluid, but to drain it posteriorly. And it's interesting, this very thick fluid starts to come out. Oftentimes the fluid will stop as a little crystalline deposit clogs the break. And I literally, with a 0.12 forceps, have to pick out those pieces, and then the fluid starts to come out again. But it's very gratifying and a quick way to resolve the subretinal fluid. I don't know if you tried.
Yeah, so if it's a much more prominent case, I try to perform the external drainage from the scroll side. It's much safer. So otherwise, just like I told you, we don't need to touch any posterior area. It's encounter the opening of the whole breaks. You can encounter PBR very easy, the younger proliferate case. So in the various cases, I agree with your talk to use powerful carbon so you can displace subretinal fluid to a peripheral area. And some that crusting the debris with stacked breaks, as you told you.
Yeah.
Thank you very much. Dr. Vahab Sethi, do you have any comments on this one?
Excellent cases, Dr. Oshima. Thank you so much. I just had a quick question for you. How do you tackle the angiomas? You showed us you do cryotherapy as well as laser. So what is your endpoint to treat an angioma with cryo or laser? And do you treat the vessels as well?
Basically, if the most effective tool may be the intraocular cryo, but we don't have it. If the very giant angioma, it's not easy to stop the activity. So you only use the laser. Even your laser coagulation, you can only coagulate the outside. You cannot do the inside. So the reason why I use the cryo, the reason why I combine with the sclerectomy, because it's a much severe cryo. Because the severe cryo can make the much strong adhesion and gradually to make the activities regress. And the laser only is a very small one, small angioma, small microorganism. Otherwise, I don't think laser makes sense doing with such a giant. Some doctor also use some suture to suture the fetal vessel during the surgery. It's very technically very difficult. And also according to some other paper, you can see even use the technique or remove the angioma, they still encounter some recurrence, you know. So I don't like to use the so challenging technique because it's a very young patients. They have very good future. So I try to use a much more less invasive approach at the first surgery to this one. And you know, the reason why I don't use the silicone oil. I just use gas. I discussed with the patient several times. If silicone oil can go to the screw much earlier. If you use the gas, you need to face down maybe one week or stay in home. But I still choose this one. Actually, the proliferation actually maybe much more less than the silicone. Once less under silicone, where you make the proliferation, it's very not easy. At least for me, it's not easy to treat.
Okay, thank you very much, Dr. Oshima. Fantastic cases.
You're welcome.
Great cases, Dr. Oshima. Really great cases. And your camera, can you tell me about your camera again?
What?
Your camera.
My camera? Oh, yeah. You know, it's a very famous Japanese one. I asked about several doctors worldwide. You know, this is Ikegami camera, 4K. I think they also have the branch in the US, in Canada, also in Brazil. I think it's commercially available. It's a 4K camera, high definition 4K camera from Ikegami.
Ah, very good.
Yeah. Otherwise, Sony is not so bad. Sony cameras are very well, very good.
I use Sony. Yeah.
Yeah, it's very lovely.
Yeah. Okay. Thank you very much. Now, the next case will be presented by Dr. Gustavo Honey. Dr. Gustavo is a friend from Brazil, an enthusiast for video and cinema. It's a pleasure to have you here, Dr. Gustavo. Can you share your video, please?
Sure, of course. First of all, thank you. It's an honor to be here. Hudson, thank you for the invitation. Rafael, thank you for managing the session. It's nice to see old friends and see new friends. Let me just share the screen here. 1 second, Rafael, and we will have it. Okay, now we are here. Let me share it. Can you see the screen?
Yeah, that's perfect.
Okay, so let's go. So this is a case which we had a fallen IOL, so we decided to perform scleral pockets. And what you're gonna see in the next moments is that the trocars will be inserted through these pockets, okay? It's a technique I learned with Dr. Potamides from Cyprus. Here, I'm putting them through the pockets. Then I do an anterior vitrectomy because you never know if the iris is, if you have vitreous in the iris, then there you can see the IOL. We do a very good vitrectomy, especially a periphery shaving, because it's really easy when you bring the IOL to provoke some retinal ruptures when you grab and you bring it. So you must be gentle. You bring it through the pocket, and you already might bring, if you want, the trocar together. You leave it, you adjust the haptics under the pockets because they are safe and make the haptics more stable. Here we suture them to make them close. You can also later close the conjunctiva, and it's not often, it will be very difficult to have some tilting. And this was a case which had a hard cataract, so the patient already had before some sutures. I had to cut the sutures out because they were distorting, making some image distortion because the cornea was too tight on the stitches. And that's it, guys. I'm open for questions.
Thank you very much, Dr. Gustavo. Now I'm invited Dr. Yoshiro. Do you want to comment on this one?
Okay, absolutely. So Gustavo, thank you so much for the beautiful surgery. Fantastic outcome. Honored to be on the same webinar as everybody here. And I just have a question. So first, that was a two focal peritomies, I assume, not 360.
Sorry?
Those were focal peritomies, not 360. Those just peritomy dissection of the conjunctiva over where the trocars were inserted, not 360 degrees.
Yeah, that's actually, I always try to make 180. One from, that's what you mean? One from the position of the trocars? I didn't get you, sorry.
Oh, I see.
Sorry?
A peritomia.
Oh, yeah. Okay, the peritomy. Okay, no. I just dissect the region where I'm going to do the pockets. That's all.
Mm-hmm. Okay, fantastic. And then I saw that the trocars didn't seem to be exactly 180 degrees apart, but you were still able to maneuver the lens very nicely without tilt, and it was really nicely centered. Do you think having the pockets there somehow gives you more flexibility?
Actually, secondary IOL implantation, it's my favorite procedure, as I can see. And when I see some new thing, I'm always trying to do, because, I was discussing this in another webinar, and people were saying, which is the best technique in your way, or which one do you like to use? Well, it depends on the mood you have that day. And this day I wanted to try some new thing, and I never tried that one. So this was the first case I had with it, and I liked it. But nowadays I prefer the Yamane technique.
Fantastic. Thank you.
Thank you for the questions. Thank you.
Thank you, Dr. Yoshihiro. So Gustavo, do you want to share Lucan's video? Lucan is a friend and could not be here today because he had a family problem. So
okay, give me 1 second, Rafael, and I will do it for you. Let me just, because I have to open the file first, and then I share the screen.
Okay, no problem.
I have his video ready here if you want to, but if
Gustavo,
okay. I already have it.
Okay,
Gustavo, there is another question here. Which distance from the limbus are you inserting the IOL? Andre?
That's a very good question, and I'll let you know. So I dissect the conjunctiva, as Dr. Yoshihiro already asked, at the region where I'm doing the pockets, and the inserting plane is 4 millimeters from the limbus, and I enter the pars plana 2 millimeters from the limbus. Okay, so you have a distance 2 and 4. The pocket, the total length of the pocket is 2 millimeters.
Yeah, thank you.
So now I have Lucan's video ready. Let's go here. So let's go ahead. So this one, let me just play. Can you see it?
Yeah, perfect.
Okay, perfect. So this was a case where there was a big retinal tear, superior one, and Lucan used perfluo silicone oil, and at the end, the following day, he saw he had some PFO under the retina, as you saw in the initial OCT. Okay, so the idea here was to use active aspiration with a 41 gauge needle, and without infusion, and leaving the oil. So to try to make it, you don't have to remove all the oil, repeat the procedure. Sometimes you have retinal detachment redetachment after that. And the trick here is to find the right plane, not touching the RPE, and very gently you pass it, and you start with the active aspiration. And the secret here is not desperate and having a steady hand, because it takes time. Remember, the caliper of the open of the needle is really small, and through 41 gauge, it takes a longer time. That's it. After the surgery, there was no PFO under the retina, and that's the follow-up of the case.
Yeah, beautiful surgery. Beautiful.
Very good, Gustavo. So I just had a comment. I just did demo yesterday exactly subfoveal PFCL removal, and somehow this 41 gauge didn't work. So I made a 27 gauge meringotomy knife, made a small nick at the edge, and used the brush, and it came off.
Yeah, we also with active aspiration.
Yes, yes. Good
Yeah.
case.
Good
Yeah,
case.
Dr. Lucan is a brave surgeon and really skilled. He's a master.
Yeah, yeah, it's a very, very beautiful technique. So, Hudson, do you want to comment on this one? Your mic is off, Hudson.
Okay, I was just telling that Lucan is so cool and making videos as well. And we learned a lot from him. And unfortunately, he cannot participate today, but his case is great. I have exactly the same case that I did with the same cannula. We used this 38 gauge. And actually, it narrows down to 41. And under silicone oil, it works pretty good. I don't need to remove the silicone oil, such as in this case. I carry on the vitrectomy. I put the infusion line, very low pressure, very usually about 20, 15, 20, just to maintain, to keep the eye a little hard. So I go very fast with the 38 cannula, the 41 that narrows down, and I remove the perfluorocarbon from the subretinal space. And these cannulas that I use from Med1 here, I think they are all over the world, but the distribution here in Brazil is very good from Med1, and it's really amazing. And I like doing that technique. Very few times I had to remove the silicone oil, to remove the perfluorocarbon, because I usually don't have much of these complications, but the ones I had, I did not need to remove the silicone oil.
Yeah, thank you, Hudson. It's a great video and great technique. Lucan is very, very good surgeon. So we shall proceed to the next one. Dr. Yoshihiro Yanakawa. Dr. Yoshihiro, do you want to share your screen, or do you want Hudson to?
Yeah, I have the video here ready.
I have it shared also.
You want to share it?
I can share so I can kind of stop and go. As
okay,
we
okay, sure. Go ahead.
So this is a case of anterior persistent fetal vasculature. So PFV, you can divide into 3 different types. Anterior, where you only have anterior segment involvement. Posterior, where you have the stalk. And anterior posterior, that's the classic stalk connecting the disc to the anterior segment. And this is a 2-week boy referred for just leukocoria. And here you could see the massive membrane and fibrotic tissue over the pupillary plane. And the most important thing when you have these children is to rule out retinoblastoma. And so we have to be sure we do a good B scan, take a good family history, and take a good look in the other eye also, make sure there's no retinoblastoma. Here, the view is not very good, but we did a good B scan. Another clue is that you can see that the ciliary processes here, I think you can see my, my mouse pointer is extending towards the center of the eye. That's a clue to PFV as well. And so we're going to fix this eye. And as you can tell, it's a little small, even for the patient's age. And here we're inserting the infusion in the anterior chamber, not in the pars plana. And the reason is because in PFV, a lot of times you can, even if it looks okay on the ultrasound, you can have retina that's very anterior, and you don't want to nick that as you go in, especially here because you don't have a view. If you did have a good view, you can examine the pars plana and do pars plana vitrectomy, but here we don't, so we're not taking any chances. And here we're putting the 2 other cannulas in the anterior chamber too. You can either do this, which I think I learned this from Phil Ferrone. It stabilizes the anterior chamber so it doesn't collapse as much. But usually I make I do a conjunctival dissection and make a sclerotomy at the iris root anterior chamber. And we have the cutter with very low cut rate, trying to eat away at the membrane. It's very tough, so we use an MVR blade to create the initial plane so that we can get through this thick membrane. And then now we can kind of make our way through. Cutter's working a little bit better once we have an edge. And we're approaching this very solid looking mass here, and the cutter is not able to eat through. And this is 23 gauge, by the way, just a bigger instrumentation. And so we use scissors to try to cut this membrane off. And that works well. And here we're doing a vitrectomy. We don't have to be aggressive here. And this is just I like this image a lot. It's a good retro illumination of the round ring that you can see in PFV, which is still contracting the eye together. And we're going to cut this ring because our view is pretty good. And that's my favorite part, where you can see the eye kind of snaps open. And here people are different in their opinions about whether to remove this extra tissue or not. Here we are, and I'm making a point to do good scleral depression here so that we can see everything, make sure we're not cutting and causing traction onto the retina. And that may help prevent rhegmatogenous complications later on in life. And I always like to finish these cases with air so that there's no vitreous incarceration. And it's good to follow up with fluorescein in these cases. A lot of times these eyes will have peripheral vascular changes. We're not really sure what the implications are of that. It's often quite mild, but it's something that we monitor. And the patient received aphakic contact lens correction and did very well.
Yeah, thank you very much. Beautiful case, Yoshihiro. Now, Dr. Oshima, do you want to comment on this one?
Hi, Yoshi, great case you did. They're perfect. So do you think, what is the cutting rate and the bounce you use for this case, for the anter-chamber manipulation?
Absolutely. So this was 23 gauge. And when I was cutting the membrane, you know, for regular cases right now, I do 10,000. I think that's wonderful. But to get the really thick tissue, we just kept going down and down and down and down. Sure. I think ultimately this was like 1,000 or 500. And yeah, keep going down, down, down.
You know, there are two point about this cutting. You know, previously we just like to drop the crystal lens. We use a very low cutting, that like the, 500, 10,000. And the one thing, just like you right now, we have the dual pulse, very high speed cutter. High speed cutting, the high speed aspirate. Cutting much small, very small debris, they aspirate together. So how do you think about the 25 dual port cutter? Did it work for this case?
Great question. So I like using all gauges, 23, 25, 27, depending on the case. And I still have a bias towards, if I'm cutting big membranes or if I want really robust instrumentation, I'll do 23 gauge, which tends to be the tougher cases in children's eyes, which is ironic because, we think of smaller eyes, smaller gauge. And actually, we're writing a paper together on 27 gauge for pediatric cases. And I promise we'll have that written soon. I apologize. We've been working on that for a while now.
So anyway, in this case, you need to suture the pulse, suture the cornea wound. Do you need to put a stitch?
Yes. So in pediatric eyes, I always suture. You never know what the kids are going to do. They'll be rubbing their eyes. We don't know if the parents can get their the drops in. So subconjunctival antibiotics, if it's a long case, even betadine on the eye, and always suture, especially if it involves the wound involves the cornea.
Yeah, very great job you did. Always learn a lot from your kid case.
Thanks so much.
Perfect.
Thank you. Great comments, Dr. Oshima. Now, Dr. Saad Wahib, do you want to comment on this one?
Sure. Yeah, this is a great case. I was just wondering, we spoke about the gauges, using 27 in this case, but maybe it's not a good idea because of the thick membranes. And I agree. I think 23 probably works better. The other comment I have is I think these kids benefit also most when you look at their post-operative visual rehabilitation, as you said, with the use of contact lenses. Otherwise, they get deep amblyopia. But that's a great case. Thank you.
Thank you. I definitely agree with working closely with a pediatric ophthalmologist who is very aggressive with patching therapy and fixing that amblyopia, because anatomically, everything looks really good here. And I think we have a good opportunity to give this child good vision.
Sure.
Yeah. Thank you very much. Beautiful, beautiful case. And The next one to present will be Dr. Natarajan. So Dr. Natarajan, do you have your video here?
Yes.
Yeah.
Yes, I will show.
Thank you. So Dr. Natarajan is here from the first Retinawesome. So he's almost a member of it.
One second. Yes.
Oh, that's okay.
Yes. So can you see my screen now?
Yeah, it's perfect. Thank you.
Okay. So this is a 65-year-old pseudo-faking male with a history of scleral buckling done 2 months back, and then came with a proliferative vitreoretinopathy. So I used a 23 gauge vitrectomy in progress. Now, after completing vitrectomy, you can see there are multiple retinal holes all around the periphery. So I think the roller buckle is absolutely not here, because whatever I do, and you'll be seeing that the entire retina is contracted because of the intrinsic contraction of the thing. So I'm trying to work under air. When I do a endodrainage and fluid air exchange through the existing break, you can see the retina is stretching and it's not going behind the contour of the globe. So that's the reason under air, I do the relaxing retinectomy. And finally, I land up by doing cutting the retina 360 degree like this, and an irregular shaped retina I get. And the reason I do this is not to lose much of retina, so that disc, macula, and some amount of extra retina is there all around. And you'll be seeing that I'm, because of the intrinsic contraction of the retina, the retina not going back. So that's the reason I had to do the relaxing retinectomy. And you can see now the anterior retina, which has PVR, has been cut and removed. And now under the PFCL, I'm doing the endolaser 360 degree to this attached retina. And I actually use heavy oil in those sort of eyes. And at the end of 3 months, then I remove, or if I feel there's a risk of recurrent detachment, then I exchange with 5,000 centistrokes oil. You can see the entire retina attached. And this patient actually, I think about 3 months later, I removed the oil and then did and this was the picture. You see the steroids in there, and the vision around 6/36 was there. I have one more case, similar one. So that's the reason I'm showing the. So here again, you see a total retinal detachment with a PVR D3. And now you're seeing the disc region, and then there's a posterior retinal break. And again, I'm doing endodrainage and doing a fluid air exchange, and then make sure that again under the air, I'm doing the relaxing retinectomy using the diathermy. And here I'm actually cutting the retina, and then using the cutter to cut the anterior retina, so that remove all the anterior retina totally. And all this is because of the intrinsic contraction, apart from the anteropost retraction, which is on the surface. After removing the membranes, sometimes the retina does not. You have to go under the, and then use the PFCL, stretch the retina, and then finally make sure that one of the reason I do under air is because sometimes in case I do under fluid, I've seen the retina curls back, and sometimes I'm not able to uncurl it at all. So now I'm doing an air oil exchange, and you can see the laser done all around. Thank you, and that's it. And this is the post-op picture of the 6/60 vision.
Thank you very much, Dr. Natarajan. Very challenging cases, very difficult cases. And so I want to bring André Jucá. Do you want to comment on this one, André? Oh, I think he's off. So Dr. Yoshihiro, do you want to comment on this?
Yeah, absolutely. Dr. Natarajan's the master of the most challenging cases. And that was beautiful surgery. And I just want to learn a little bit more about the rationale and the benefits of doing the anterior retinectomy under air as opposed to doing it under fluid. And if you can repeat some of that, those pearls for us.
So one of the thing is that I learned this. I've seen sometimes Steve Charles doing it. One of the things we can stretch the retina after making sure that all the membranes are removed. And I have not shown the entire thing. It's an edited video. Many times I go back to fluid and see how the retina reacts, and then again go back under air. And when you're 100% sure you removed all the membranes on the surface of retina and behind the retina, and then I think I feel I'm entitled to do a retinectomy, a relaxing retinectomy, because otherwise, if the membranes are not removed and the whole retina, I think will just get crowded on the disc. So I think under air, other advantages, you can keep the air pressure for higher than the fluid, maybe even at 60 for a few seconds, and cut the retina. And if you've seen the second case, I used the diathermy to cut so that there was no bleeding, and then slowly the retina falls back. And then use the PFCL, and you can use the retinal massager or the brush to flatten the retina.
Thank you so much. I think these cases were a little special too, because it's unusual to see this much PVR after a primary buccal. And so I think these patients probably started with a lot of intrinsic retinal PVR as well. And so, yeah, these techniques are wonderful. Thank you for teaching us this.
Thank you.
I also want to comment on this case. I love to do lasers, especially after fluid exchange. It seems that with the wide-angle vitrectomy viewing systems, you see the whole periphery a lot better. So sometimes you have a hole, Natarajan, in the very far periphery. You cannot reach it during the vitrectomy, even though you make indentation, you use wide-angle lenses. But if you do some laser that is not quite enough, after fluid exchange, you put the lens, you see a lot more from out of the periphery. So great case, you know, and these cases are really challenging.
Yes. And I decided now onwards, I'll do only complicated cases. I don't want to do simple cases anymore.
Thank you.
Yes.
I just wanted to comment too. Great case and great results. And I too, Hudson, love the peripheral view that air affords, obviously. However, in cases like this, when I'm doing a 360 retinectomy for terrible PVR like this, I'm worried about the retina slipping when we're putting in the oil. And lately, what I've enjoyed doing more than using air is using perfluorocarbon, doing the retinectomy under perfluorocarbon, and we can in real time really see how much of the traction we've relieved and how much more we need to relieve, and then just going directly to a perfluorocarbon silicone oil exchange and avoiding air at all. I find there's virtually no chance of slippage, and it's just a very much more controlled scenario for me. I wonder what other people
Excellent point, Robert. I think we had to, probably many cases I do with PFCL, and I specifically selected because some patients like this, I don't know how to classify which one to use PFCL and which one to use air. But I think one of the things is when I use PFCL in the first case, I think the PFCL went every time subretinal. So I decided instead of using PFCL, I'll do everything under air. And I did a fluid air exchange, make sure the retina was flat. And then use the oil by putting the first drop of the oil, pouring in front of the optic disc so there is no slippage. I agree with you. And I think that's the reason in giant retinal tear with a floating retina, it's easy to do a PFCL oil exchange because everything is under excellent visualization. So I think I have to probably think more to write specifically which case only to use PFCL and which case you should switch over to I think it's a valid point. Maybe I'm writing a book on like principle and practice of surgery, which is surgery, which I think I have to segregate this. Good, very good point to think.
Yeah, thank you very much for the comments, Dr. Robert Devaney. So, Dr. Robert, you're the next one. Do you want to share your video or
I have Dr. Devaney's video here, and let me share it now. It's really cool, Dr. Devaney. This video was amazing. I tried to cut it a little bit, but no, everything is so important. Can you see the screen right now? Okay, yeah. I'll start it. So it's going on.
So I think this was just quickly showing the indications which we all know for the Argus implant for patients with retinitis pigmentosa with light perception or worse vision. And this was one of our first cases, actually. It's really fun surgery and technically quite challenging. Here's where the band is just being sutured into place. You can see the ribbon reflected anteriorly onto the cornea. As I said, these are virtually the only buckles I ever do. And they're big buckles, huge buckles. The electronics of these Argus implants are very large, and one really has to take care to cover them properly, otherwise they'll erode through the conjunctiva. There's the array of 60 electrodes now on the ribbon. One has to be very careful not to use regular instruments because it'll damage electronics. We use only silicone tipped instruments to handle all electronic components. There's the array reflected on the cornea before it's inserted. Now through a very large 6mm incision, it's inserted through the sclera. I use, again, soft-tipped instruments, typically a soft-tipped extrusion needle to manipulate the array. And then with this titanium tack, it's tacked into place. And as you can see there, the goal is to tack it onto the central macula. And that's the most stressful part of the surgery because one really has only one chance. This isn't quite in sequence. This is now securing the electronics there onto the retina. This is again showing the array being inserted with silicone tip forceps into the sclerotomy. And again, the tacking is the most stressful part. A lot of surgeons, younger surgeons, don't have experience with tacks. We used to use them a long time ago, not very successfully for retinal detachments, and everyone has abandoned them, but the technique remains as a good technique. Now, because the electronics are so huge, we can't just close the conjunctiva over it. We use irradiated pericardium called tutoplast to cover the electronics before closing the conjunctiva to avoid extrusion. This is a video showing how 3 months later, this was our first patient. She was able to identify these squares very successfully. You can see her pushing on them. This was just a test that she failed miserably on preoperatively, and it was really a very emotional, positive time for her to be able to suddenly see these things. Every time she pushes it, she gets this positive reinforcement from the computer. And then 1 week later, you can see on the OCT there how the electrodes were flat against the surface of the retina. And that's the kind of position we want. We don't want it to overlap on the disc. We want it just to cover the macula. These are several cases, I guess, that are being shown here. That's another one, good position. Amazingly, these are tolerated extremely well. Yeah, this one patient developed 20/160 vision. And she was able to, she wrote me a thank you card with letters about 1 inch. And it really changed her life. There's another one. It's super, super fun surgery to do. And it really incorporates all aspects of everything we do. You can see it's really very well tolerated despite the huge buckle. They're really hardly swollen post-operatively. Tragically, one of the patients that I did an Argus on just died of COVID, which is such a shame. Again, that's the first post-op day. They're hardly swollen at all. There's the first 9 or 10, I guess. Yeah, so the visual rehabilitation starts about 4 weeks post-op, and that's really a big deal. This was the letter this one lady wrote me. She wrote me that thank you letter. It's pretty amazing. She was light perception preoperatively. We did apply and were successful. Yeah, this lady became quite a celebrity in Toronto, was really even in the local magazines. So the big question is, what is the future? When these slides were put together, the hope was that these implants would keep improving and the sensitivities would keep improving and the software would enable facial recognition and color, et cetera, et cetera. But the reality is that the economics are such that the company is basically unable to continue, at least at the present time. It's just such an expensive endeavor. In Canada, in Germany, some countries, we were able to get funding. I believe in Saudi Arabia too. But overall, it was a very expensive endeavor, and they really ran into financial problems, as have virtually all companies making these retinal implants.
Yeah, thank you very much, Robert. Fantastic job, fantastic results, and mainly this changed patient's life. That's what we are seeking. So, Hudson, do you want to comment on this one?
Yeah, Dr. Deveni, I get almost emotional when I watch these videos, especially this video from this woman from India. You know, this is amazing. I can't believe that surgery is gonna stop. I don't know. I remember when I did a retinal fellowship with you and Dr. Lam, we had this macular translocation buccal system surgery. It went on for a while, and then after some years, it was discontinued. And I think we still have some application for that. But talking just comparatively with the Argus 2, do you think the Argus 2 could have a future, a better future now, but or because of the laboratories or other economical problems, it might stop?
I think it's very interesting. You know, there's good and bad when private industry becomes involved in medicine. In a lot of ways, it's very good because competition breeds progress and people try and outdo others and we get better and better development. However, it also means that the bottom line is very important, and if the finances are such, then it just doesn't continue despite their role. And I think that's what we're really seeing here. The main financier for Second Sight, who literally gave them tens of millions of dollars, essentially sealed their fate, because he wants them to not concentrate on the Argus, but to concentrate on the Orion, which is the group of electrodes that they don't place on the retina, but they place on the occipital cortex. And the rationale is the Argus is good for patients who have an intact optic nerve and an intact eye. The Orion theoretically is good for all patients who are blind. So this guy, being a business guy and being an investor and having various personal reasons why he's so invested in blindness, has dictated essentially that that's the direction they should go. As to whether the Orion will ever prove useful, I don't know. As a lot of people probably know, they have done a few Orions in the world, essentially as a proof of principle, just to ensure that at least by electrically stimulating the brain, epileptic seizures aren't being induced. And the patients do see some vision, some light sensations. The challenge, of course, will be to enable some sort of spatial orientation and some sort of useful images. And whether that'll happen, that still remains to be seen. I'm personally pretty skeptical. Not to mention it's a much more dangerous endeavor to be drilling into the head and putting electrodes onto the brain than us implanting into the eye. So where that'll go, I personally wouldn't be wanting to invest any money into that, but we'll see where it goes.
Yeah, very cool. And I just want to welcome Dr. Wai-Chin Lam, also my professor, as Dr. Rob Deveni. And I want to know whether Dr. Lam wants to comment on Dr. Deveni's case for Argus 2. Dr. Wai-Chin Lam just came in, and
yeah, sorry, I came late. Hi, Rob, and hi, Sad. And I think the hour difference between Hong Kong and Brazil got me mixed up. And anyway, I think the Argus 2 is an amazing tool for the patients, and it has allowed great mobilities for those patients. And it's too bad that it doesn't get to carry on, because the company had decided it is not commercially favorable for them. But I've seen Dr. Deveni operate on those patients, and I also see them being trained to use the device, and it has a incredible result for those individuals who otherwise will be totally disabled, unable to ambulate, and unable to do a lot of the things that the devices allow them to do so.
Thank you very much.
Ask one quick question. Rob, I read with interest the publication that your group, the Argus Consortium, published about a year ago or a couple of months ago about the rates of complications. And the complication rates were much less in the real world after approval compared to the clinical trials. And I always wondered, what kind of modifications did you guys make?
I think a lot of it is experience too. You know, and some centers, we got very quick at it. I think my fastest one was just over an hour. Some centers, they took 9 hours. And obviously, the quicker the surgery, the less likely I think you're going to get complications, and just go and do the job and get out of there as quickly as possible. I think in terms of the initial cases versus later cases, the biggest change was the tutoplast, that irradiated pericardium that was placed over the large portions of the hardware before closing the conjunctiva. And that honestly took the longest part. It was like doing fine, meticulous oculoplastic surgery, just placing these pieces and suturing them down to really cover all the portions. But that virtually eliminated extrusion, because I think that was the biggest issue. There weren't any major complications otherwise. There were a couple cases of detachment and hemorrhage, and I think maybe one endophthalmitis, but they were comparatively very rare. The worst complication I had in my patient was a very upset patient, because after about 3 years, her implant just stopped working. It literally stopped working. The engineers did not know why. The intraocular portion could no longer communicate with the extraocular portion, and the image could not be sent. And there was 1 or 2 other cases like that reported as well. Not that it's a huge surprise. There's no other piece of electronics that we buy in life that we expect has 0 chance to malfunction. The problem is when this electronics happens to be implanted in someone's eye and it malfunctions, after it had changed their lives, they're very unhappy. And it's not a trivial endeavor to try and take one of these out and put another one in. So it was an amazing device with some but rare complications for sure.
Yeah. Thank you, Dr. Robert. Dr. Marcelo Murillo Sasamoto, do you want to comment on this one?
Yes. My comment is that I think 1 year ago I had a conversation with Rajat Agarwal, one of the creators of the Argus One, I believe, and his desire was to have a Argus, a low cost Argus for people in India. So he told me that maybe the future 10,000 cost per Argus would be great. But my question is, during this consideration that Robert made, do you think in the future would be possible to have this Argus 2 a low cost for all the people who want it or who need it?
I don't know. I think the problem is it's such an expensive endeavor, not so much to make one of these implants, but to support it and to facilitate advancement. For every case that we did, Second Sight would send typically 2 engineers to come during the case and monitor the progress, and then not to mention the whole post-operative process of fitting the implant to the patients electronically, and then the whole rehab portion. It's all very expensive and very labor intensive. You know, for example, the first step post-implantation at about a month is that each of those 60 electrodes has its threshold determined such that the electrical stimulus keeps being increased until the patient can see it. And it's done so in sequence for each of the 60 electrodes. And then software is written specifically for that patient. And then the next step is the whole rehab process. So it's so much more than the development of the implant and the manufacture of the implant. There's a lot of steps, and it's just expensive. But yeah, I don't know. I mean, even at 190,000 Canadian dollars, they couldn't make this endeavor work financially. So I don't know how a $10,000 implant, in terms of all the other costs, would be viable. But maybe.
Thank you.
Thank you very much. That fantastic cases. And so the next one will be Dr. Vaibhav Sethi. Do you want to share a screen, Dr. Sethi?
Sure.
Dr. Sethi, do you hear me?
Yes, I can hear you.
Yeah.
Can you see my screen?
Yeah.
Yes. Can you see the video, please?
Yeah, perfect.
Okay. So this was a case of vitreomacular traction of an old lady and in a right eye. So basically, in all cases of vitreomacular traction, I go ahead and stain it with triamcinolone, and that really helps me to delineate the posterior hyaloid very well. So in this case, I'm showing you because I had a difficulty in basically peeling off the posterior hyaloid to basically reach the traction. So here you can see I'm trying to shave off the cortical nucleus all across, all around the adherent posterior hyaloid. So basically I'm avoiding any anterior posterior movement because that can actually create a macular hole. So I'm trimming the vitreous cortex all around and there's adherent posterior hyaloid at the macula as well as in the peripapillary area. So after clearing off the tricot and increasing the vacuum to around 500, 600, and doing a 23 gauge vitrectomy, and still not being able to find a proper cleavage plane below this area so that I can peel off the posterior hyaloid. So I try now to create a cleavage plane between the disc and the macular area. Here I'm able to create some amount of cleavage plane through which I'm aiming to go through, and I'm just trying to just check whether I'm in the right space or not. So yeah, I could see that I'm holding the posterior hyaloid and trying to create a PVD, but I stopped there because if I do too much of anterior posterior traction, it will lead to a macular hole formation. So now I go back again, and now fortunately I do get a cleavage plane all around, and here you can see I'm just with the cutter I'm able to open up the hyaloid and basically atraumatically release the traction. And to be on the safer side, I do always go ahead and peel the ILM as well in all the vitreomacular traction patients for my own satisfaction, so that that confirms the proper clearance of the traction, as well as in case I've created an inadvertent macular hole, this will help me in treating that as well. And I end up putting air or gas depending on the case. Thank you very much.
Thank you, Dr. Sethi. Dr. Rachel Lam, do you want to comment on this one?
Sorry, actually I missed the video. I couldn't see it properly, so I think you have to pass the comment for that. Sorry.
No problem. Dr. Natarajan, do you want to comment on this one?
Yeah, no, I think excellent point, and I think you have to be aware of like the happening of macular hole, and I think we had also discussed with the patient before. I think, as he mentioned, atraumatically induced PVD using the cutter instead of using the anteroposterior suction in the beginning, and he used steroid stain and also did a ILM peeling without complication. And I think it's important because we have to know that the macular hole is one of the complications, and which I think we have to prevent it. I think Vaibhav, we have done a good surgery. Great.
Thank you very much. Dr. Vasco Bravo, do you want to comment on this?
Yeah, it's a nice case. I think it is a really good approach. Sometimes we have these vitreous really attached, and I think Dr. Sethi was very carefully, and he did the right choice doing this. The triamcinolone helps a lot on those cases for sure, and I think he performed really well. I think we have to take care sometimes, mainly for the younger, the fellows. Sometimes they go like, oh, vitreomacular traction, let's detach the vitreous, but we have to be really careful in those cases, and we can't be so hungry as when we try to detach the vitreous when we perform a retinal detachment or another type of vitrectomy that we can be more strongly have a more strongly approach for vitreous detachment.
Thank you very much. So shall we proceed with Dr. Saad Wahib? Do you want to share your screen for the next case?
Sure. I'd like to first start by thanking Dr. Nakamura for this beautiful chance he given me, not only to see everybody, but also to connect with old friends, Dr. Waishin Lam and Dr. Robert Devenier. Me and Dr. Nakamura, we did our fellowship together, and I'm not going to say how long ago, Hudson. I'll just keep it between both of us. So before I start,
long time ago.
So this was a case that was sent to me for second opinion. He's a younger guy. He's actually a football player in one of the famous football matches here in Saudi Arabia. And he was referred with this history of dropped vision for, when I saw him, it was almost 2 months. He does report a history of transient exposure to one of these handheld laser pointers. It was very brief, very uncomfortable, and then his vision dropped over 1 week. When I saw him, his left eye, which is the affected eye, was counting finger, normal anterior segment examination, and this is how his fundus looked like. You can see the full thickness macular hole. I've gone into the habit of doing OCTA for these patients lately because the recent reports talk about OCTA biomarkers in the form of the fast zone and the cystic changes in the deep vascular plexus that can be prognostic factors. This is just again showing you the hole, which actually looks like it's moderately large, with the classical edema at the edges and the subfoveal hyperreflectivity, which is usually seen in these cases. And when you look at the size of the hole, there are different ways of measuring the size. You can either look at the apical or the basal or the narrowest, and he's 550, so he's considered a moderately sized hole. And at that stage, the previous retina surgeons that I've seen have advised him to wait for at least 2 or 3 months. And I said to him, there's a chance that it might spontaneously close, but I think it's very small, and I did advise surgery for him. So this was a 25 gauge vitrectomy using the Constellation. I do agree with the previous speaker. You want to induce PVD. I used triamcinolone, but I think I must have used a little bit too much here. In the young people, you want to watch for difficult highloadal induction, and sometimes you have to restain again, and you want to be patient, give it some time, allowing the vitreous to hydrate. And I think with patience and the fact that you make sure you have a good grasp on the hyaloid or the opening, and then you can see how you can induce the posterior hyaloidal detachment. Now the question is how far anterior you want to take it. I don't think in macular hole it really matters that you want to take these cases anteriorly. And then after that you stain. I stained with membrane blue, and the idea is to do an ILM peel. In this case, I decided to do the macula sparing ILM, and you can see I'm trying to start the rhexis of the ILM. You can certainly use the Fennes loop. I feel comfortable with the forceps. I used to do bigger ILM peels, but now I'm doing smaller ones, trying to save ILM just in case if I have to come back. I shorten this with the cutter. Now, tip, when you do that, please lower the vacuum, otherwise you can pull the whole ILM. And then after that, once you've done the trimming of the ILM, you do an air fluid exchange, which I've done. I'm not trying to stuff the membrane into the hole. I don't like to do that, but I'm just trying to make sure the ILM is on the hole. And I used SF6 20%, but I would think air would probably be also sufficient. I usually bring these patients within 2 to 3 days. I think if they're going to close, they will usually close after 2 to 3 days. And we're lucky with this patient, and his vision has actually improved. And this is 1 week post-operative picture showing improvement of the visual acuity. His IOP was a little bit high, and that's this is, I think, because I used a bit too much of triamcinolone. But within a month, his IOP came back to normal. His vision came actually to 20/40. And I think if you look at the different OCTs, I think with time, the macular structure tend to come back. The external limiting membrane, the ellipsoid zone, and the photoreceptor outer segment, I think, is going to grow in these cases with time. Just one final word on the use of these high-power, high-tent lasers. I'm not sure how is the situation, in your country, but in my country, it's easier. You can buy these things over the internet. Teenagers and kids can get them, and you can play with them, just like this unfortunate guy. And I think we need more restriction. So I think that concludes my case. Thank you.
Thank you. Thank you very much, Dr. Saad. I would like to bring Dr. Gustavo Honey. Do you want to comment on this one, my friend?
Absolutely, absolutely. First of all, I want to say congratulations to Dr. Wahib. It's a beautiful and very rare case because the macula was burned, and usually when you think about traumas in football players, you expect to be through an impact or the ball or something like that. The only thing, which is my humble opinion, I would do the posterior hyaloid detachment as much as I could. That's the only different thing I would do. And another thing, in young patients, I don't think you had too much triamcinolone. The opposite, you did it rightly. because it's really difficult to detach this hyaloid in young people. So, and it is easier, like you did in your video, to use the bursa premacularis to detach the hyaloid. Congratulations, beautiful.
Thank you. Thank you, Gustavo. For the first question, I thought I used too much triamcinolone because the IOP of the patient went up in the first 2 weeks or so. And then it's interesting you say that because we have unfortunate high number of these cases. I think there are a few papers published in this range, and I think one of the biggest paper came from King Khalid Riyadh with the highest number of handheld laser-induced macular hole injury. So I'm very hopeful we can get this thing controlled soon. Thank you.
And just to answer your question, sorry, it is also really easy to here in Brazil, at least, to buy these lasers, but so far, and thanks God, I never had a case like that. Congrats again.
Thanks.
And Sad, I think you can use filled and use steroid so that I think you don't have to use much steroid. Probably just circulate and go small advice in case you see that the particles are bringing the angle.
I can't hear you. I'm sorry. I lost you.
No, can you hear me now?
Yes.
Your sound is strong.
I think Dr. Natarajan is having a connection problem. So
if I may give a suggestion to Nati, because his sound is chopped, he can type the question. It would be easier, I think.
Yeah, and we can pass it through Dr. Wahab.
I think what Dr. Natarajan was saying is that the residual triamcinolone inside the eye may actually has helped the recovery by reducing the amount of inflammation, and potentially the extra triamcinolone that was used actually has this anti-inflammatory property that may have helped the healing of the macular hole in this case. I'm not sure whether that's true or not, but that's one possible kind of proposal.
Great to hear this from you, Dr. Lam. One thing I wanted to say to Gustavo, as far as inducing the PVD, I think it's a bit controversial because maybe in a diabetic, you probably want to go as far anterior as you want, but I thought in macular holes, because the disease is very posterior. Now, you can certainly induce the PVD anterior, and you can go with the hyaloid anteriorly, but then you're worried about creating peripheral breaks. So I think there's a balance between both, but I think both ways are correct.
And if I may give you another suggestion, I know it's a little bit difficult because football players move a lot. If you can do a long follow-up of this patient in the future, share it again, I would love it. Thank you so much.
Sure. He's been actually 6 months. He wants to go back to play. I've been holding him. He's a famous football player. But I mean, you think he should go back to play? I wanted to ask what the panel think. Should he go back to play? He's a very active guy, and I think he's worth a lot. So that's why they were concerned about him. I've been keeping him off, playing for now 6 months. So would that be a good idea? Should I continue holding him, or should he go back? What do you think?
After 3 months, I would set him free.
Really? Okay.
I think eye protection will be very important going forward.
He doesn't want to do that. I did suggest this to him. He doesn't want to wear any goggles, and he said he doesn't look well with them. He's a very handsome young guy. So it's not easy, trust me, when you deal with these people.
What is his final visions now? What is his acuity that
he's not in my city. I've been getting his OCTs from I've just got his 3-month OCT. His visual acuity is 20/40, 20/50.
Okay.
Now he's fine. His pressure is okay. I think he's probably ready. I did suggest for him to wear protective glasses or goggles when he goes back, but he said he doesn't want to do that. So
yeah.
I think
you can explain it to him though that if you get hit, that hole may open up again, and the protective goggle may have to.
what I'll do, Dr. Lam, I'll set him free. If something goes wrong, I'll send him to Gustavo.
Yes, good idea.
As long as he doesn't score own goals, is okay.
Well, one small thing about triamcinolone is that in a vitrectomy side eye, maybe the anti-inflammatory effect is almost 2 to 3 days. So just a comment.
Yeah, sure.
Thank you very much for your case, Dr. Saad. So we shall move to our next presenter, which is Vasco Bravo from Brazil. Hello,
Okay.
Vasco. You want to share your screen, Vasco?
Yeah, sure.
All right, Vasco. I had this connection problem here. The internet is so strong, but I don't know what happened, and I skipped for a while.
Oh, that's all right.
And if you could share, that would be
Yeah.
okay.
Can you see my screen?
That is perfect. Thank you,
Okay.
Vasco.
So first, thanks again, Hudson, Rafael, and everybody. It's a great pleasure being with such amazing team. And here I'm going to present a case of a male, 34 years old, that had a trauma with an iron material on December 2017. But he came for another friend of mine that is a cataract surgery to perform the cataract, since they had this. And so we decided to perform ultrasound, UBM, and all this thing. And it had UBM, you can see the intraocular foreign body very tight, very, very close to the wall, anteriorly placed, close to around pars plana. When he came, so we lost his follow-up and a little bit, and then he came was 2400. The conjunctiva was quiet. We couldn't see a lot of details in the fundoscopic, and no flare. Everything was okay, but had the pseudocapsular cataract because of, unfortunately, due to insurance problems that didn't want to allow the surgery together with a retinal surgery, because the cataract, my friend that performed cataract surgery talked with me, and we decided to make a surgery together. So we had the delay. And so in January, he came, he was light perception. So he had a complete cataract. And so this was the ultrasound, the B scan in 2018. And then when he came, we can see that we have increase in inflammatory findings. And we had to perform the surgery. And thanks God, the insurance approved the surgery. So here is the cataract friend that performed the surgery. You can see a lot of pigments in the capsule, but the cataract was very soft and it went okay. We implant the intraocular lens, and then we performed the vitrectomy. He had already the posterior detachment. We can see that had some inflammatory, some opacities in the vitreous. So we performed a complete vitrectomy, started to review, and we found the intraocular foreign body. I implant perfluorocarbon on those cases because I think it's good to help. The intraocular foreign body was not too big. Before I removed the trocar and increased the sclerotomy. However, when I removed the intraocular foreign body, it didn't came complete. It kind of had a disintegration. So I realized that had some disintegration, and I realized that I could actually remove most of them with the vitrectomy. Also, on those cases that are small, you can use the backflush to help positioning better the intraocular foreign body. So I could remove everything. We had some like tiny pieces still attached to the wall. We removed everything. From the review, we still had a little tiny piece that we removed. We had some of there was attached in the sclerotomy when I removed it. And then use it, as I mentioned, it had some ILM folds. I decided to perform the ILM peeling. I know that is controversial if should be done this or not. Unfortunately, I don't have OCT intraocularly, so it would help a lot. And I decided to perform laser on the area that we had the intraocular foreign body. after that, this is the OCT, 3-month surgery. The patient was amazingly like 20/25 with this residual refraction, and he was really, really happy. And that's it.
Okay, Vasco, thank you very much. Just to comment on this one, I saw a case, I think last week, from a Russian guy, I don't remember his name. He had similar intraocular foreign body. He had the cataract surgery, but he didn't implant the lens, had a posterior capsular axis, then removed the intraocular foreign body, and then implanted the lens in the capsular bag. It is an option. I think you did great, but it is an alternative. Okay. I would like to ask Dr. Weichimlam to comment on this.
Sure. Can I confirm, is that foreign body metallic?
Yeah, it is.
Yes.
So amazingly, it get, as you saw, like kind of disintegration due to the time, maybe.
Yeah, possibly the time certainly could have done it. Using a rare earth magnet may help to facilitate the removal, especially bringing up to the vitreous cavity and transfer to the forceps. Using the soft tip, sometimes when you bring it out from the sclerotomy, it may dislodge and fall back to the eye. But I think you've done it beautifully with the soft tip, removing the small fragments and clean up very nicely. So, but since it is metallic, the rare earth magnet may be useful to keep that metal foreign body in one place, and then you can remove them in total. But remember that don't try to remove it with the magnet itself, because as the instrument comes out from the sclerotomy site, especially if you have taken out the trocar, it may get caught and then get trapped in the vitreous space, and then it will be even harder to remove it. And I agree with you that it's a good idea to laser the impact site, because that could be the retinal break with the impact. So, but wonderfully done, beautiful surgery.
Yeah, thank you. Yeah, unfortunately, I don't have the magnet, so because of that, I also decided in those cases, I always perform the polyfluorocarbon, like to protect the fovea in case of when I remove it and it drops, so I can protect the macula.
I just wanted to say, I agree with Wai Ching. When the metallic intraocular foreign body is embedded into the retina, I think it's much easier and much gentler and much safer to elevate it with a rare earth magnet, as opposed to grabbing with forceps and risking further trauma to the retina, which is already likely torn. So I like to, like Wai Ching, lift it up with the magnet. It's very gentle, and then mid-vitreous, transferring it to the intraocular foreign body forceps, and then taking it out through a very generously enlarged sclerotomy to avoid potentially not getting it out easily or getting it stuck somewhere where it's very difficult to see.
I think there are also two other interesting points to this really cool case that you showed. One was this was delayed removal of the IOFB. Usually IOFB, we're trying to operate within 24 hours to decrease the risk for endophthalmitis. But the eye was really clean, no signs of any bugs anywhere. So I'm not sure if we truly know the rates of endophthalmitis after these types of injuries. And there's a lot of data from the military showing that high-speed metallic objects will have lower rates of endophthalmitis, but in civilian injuries, we're not really sure. We try to be safe and intervene as early as possible, but I think that's a great point that you make with this case. And the second is, this was a metallic, presumably, iron piece of metal, and we worry about siderosis. And I'm not sure about everyone's experience about loss of visual function with siderosis and how quickly that happens. But I think even with good central acuity, sometimes you'll have peripheral vision loss and nyctalopia. So examining the functional vision with, also ERG and stuff like that may be interesting for follow-up visits.
Yeah, it's a good point. Unfortunately, he's from a countryside area, and like since then, I don't see him. Sometimes he sends some message saying that he's okay, but that's it.
Okay, as long as he's happy, that's good.
Exactly. Actually, by the way, in the beginning, when he came first for us, and I saw we didn't have the UBM, I couldn't see the foreign body, and I even said to the cataract surgeon, look, let's do it together. Maybe I'm gonna do fundoscopic intraocularly during the surgery, and if we need, we do the vitrectomy. But after he came in, we see all that ultrasound findings and all the increase in the cataract. I said, look, for sure, we have to perform vitrectomy. This is in the vitreous cavity for sure. And then, thanks God, was everything okay.
The Yoshi's comment about endophthalmitis, I think any metal foreign body, when it comes with the velocity, it generates some heat, and usually they don't have endophthalmitis. And we have seen patients coming a few weeks later, nothing happens. But I think non-metallic foreign body, when they have, I think high risk of endophthalmitis. And this is what I've seen even in Kashmir with a lot of pellet injury, more than 1,000 people. But I think endophthalmitis was not there at all because of the velocity.
Yeah, thank you. Very beautiful case, Dr. Vasco.
Thank you.
Maybe this foreign body could be seen at a CT scan?
Maybe we didn't perform the CT scan because we had the UBM that we could really see it well. And he didn't have any other big trauma and orbit or something like that. So we didn't realize the CT due to that.
Okay. Thank you very much. Very beautiful.
Just going to say, yeah, even just a plain X-ray may be able to pick up metal, because metal has a lot of show up well on the X-ray.
Yeah.
Yeah.
I think in rural India we use X-ray. I always tell them take an X-ray and send it so that you know whether the intraocular or extra and whether it's a radio opaque foreign body. So I think X-ray is definitely the basic thing which can available in every place.
Yeah, I think it's very well said this about the X-ray and other image, because sometimes you cannot find the by ultrasound or something, depending on the type of the intraocular foreign body, or depending on who is doing the ultrasound. That is a very dynamic examination. So I always say to the fellows in the resident, look, if we have suspicious of a trauma with intraocular foreign body and you can't find, you see a wound or something, we have to perform X-ray or something like this, even for legal purpose, to make a registration of the absence or the presence of this intraocular foreign body.
Thank you very much, Dr. Vasco. Very challenging case, mainly because patient had 1 year after the visit. So it's a Brazilian problem. And
yeah. Okay. If he were in the public system, probably he would have done very fast. But unfortunately, he was in the private, and the insurance was making trouble for that.
Yeah. That is just confusing, right?
Yeah.
So now I'm gonna call Dr. Wei-Chin Lam. Dr. Wei-Chin, do you wanna present your case now?
Okay. So I'm going to show you a case, interesting case that I handled a few years back. The patient referred because of a dislocated intraocular lens implant. But it's not only just that, the whole implant with the capsular bag was dislocated. And in reviewing the history, in the cataract surgery, there was phacodonesis, and so there was some weak zonules, and they put in a capsular retention ring for the surgery, and were able to complete the surgery with the IOL in place. And then a few years later, the whole thing dislocated. So you can see on the video that you can see the capsular, one single piece tinted IOL with the capsular retention ring. You can just see it there. So I set out the surgery thinking, okay, I'm going to remove the capsule, remove the lens fragment, and then figure out how to take out the capsular retention ring and the one piece IOL. And so I start taking out that part of the cortex. And then I have something come to my mind, say maybe I don't have to take this all out. So I don't have to cut it, and I can maybe just suture this in place. So what I did next is to use the cutter to elevate the intraocular lens implant, and then using a tenopoline to suture the IOL implant into the sulcus. And the reason why it's possible is that the whole capsule is still very intact and is held up with the capsule retention ring. You can see the tenopoline needle was passed through underneath the capsule retention ring. And then I did another pass with a 25 gauge needle as a guide to allow the insertions of the tenopoline needle. And this is a double-armed tenopoline, so that so when I pull the suture up, then this will engage the haptic, and then I can secure that with the tenopoline. So you can see the tenopoline is passed underneath and above the capsule retention ring, which is still holding the capsule nicely in place. And then I just pull that up, and that, so that secured this side. And I basically repeat that same on the nasal side, the temporal side, and just because of the time, I can show you quickly. So we did also for the other side and doing exactly the same thing, and docking the needles through with a 25 gauge needle guided through the other end, about 1.5 meters from the limbus, secure that into the sulcus. And then once that is done, the IOL is still not quite center, I thought. So it looks like it's a little bit sunset. So a third tenopoline was put in superiorly, that exactly the same as the other two. And at the end, the place, the IOL is well secure in the center. So to the very end where, so at the end, I tied up all the sutures, and now the IOL is well secure. I don't have to enlarge the wound. I don't have to figure out how to take out the capsular retention ring. And the patients only have 3 small incisions on the limbus and have a nice recovery. So that's the end of the case. So it's just one option for doing the kind of securing a dislocated intraocular lens implant. In this case, happened to have a full capsule with some residual lens material and a capsule retention ring. So using a tendonylon suture to anchor them into the sulcus without having to expand them will be one options of surgery to secure the dislocated IOL.
Thank you very much, Dr. Retinal. It was beautiful surgery, very, very nice. And I will open to Dr. Natarajan to comment on this. At first, I just want to say it's very, very elegant, and you make it simpler than doing more procedures in an eye that has already a good lens inside, and you could use it. Thank you. Dr. Natarajan, do you want to comment on this?
Yeah, no, I think excellent surgery, lots to learn from watching, and I think it's really, this is where the ambidextrosity of the surgeon is exhibited, and I think he did a great job of managing the complex, the entire, with the lens dropped in and brought it back. And I think usually, because I never like to do anything anterior, so I call my anti-segment surgeon to tackle the intraocular lens, and I know many VR surgeons do it, and Wei-Ching Lan did a great job. Great, Wei-Ching.
Thank you. I like to hear the other people's comment too. Sometimes, especially when you have a capsule retention ring, it could be a bit of a challenge to remove them because the worry about that long piece of rigid material can strike the peripheral retina, and remove them takes extra precautions. So in this case, I decided this actually may be a safer way without having to deal with two components, because one is the single piece IOL, and I couldn't suture it in place normally because it's a single piece, and then I have to also remove the capsular retention ring. So those are the two considerations, and it happened to work well. And in fact, I started off thinking the same, just to take out, remove the capsule and take out each one of the kind of foreign body, in this case now in the vitreous cavity, one at a time. But it works out to be simpler by having them sutured as, and it is the capsule. Like even without the capsular retention ring, if you have a full capsule, you can also suture that in place, because the capsule allow you to use the tendoline suture to pulling suture to anchor in place.
Yeah, very good, Dr. Lam. I think your surgery was perfect, was beautiful, and I think this is one of the unique case that I think we should use the same IOL that is inside when it's dropped. Usually, when you have only the IOL without the bag, I try to avoid to use the same IOL that is inside, mainly if it's not the surgery done by me, because we don't know what happens with the optics. Sometimes you think it's okay, but the memory of the optics may change, and you can have, again, luxated IOL. And one comment interesting that I saw in one of those webinars, a friend performed the hashtag technique for those cases. And we know that the hashtag techniques maybe only for the intraocular lens, I think it's not safe. But what he was mentioned is that due to the complex bag, and in your case also the ring, it's a possibility of performing the hashtag technique. Although I think your technique was very, very clean, and I think it's safer for those type of patients. Sometimes you don't want to do a third surgery, and you think, oh, if I had done a traditional one, a fixation, maybe I had a better result. But it's just this that I want to bring up, is the possibility of doing the hashtag technique for those cases. I never did for those cases, but I'd like to see if anyone has any comment about it.
How's the hashtag technique done? I'm not sure.
So the hashtag technique, as the name say, you make a hashtag with the prolene.
Oh, okay.
So you had to put the complex over the anterior chamber, perform the hashtag, and then you pull over all this complex.
I think it's also called a
if I can comment on that, sorry.
Yeah, initially the hashtag, if I'm not wrong, but initially the hashtag was performed first to avoid the silicone oil to come in the anterior chamber for a phakic patient.
And it was described by Dr. Samuel Masket, I think in 2011 or 13, and it was described as net technique, because you cross prolene like 90 degrees, a double arm, and then you can put the IOL on it and it won't fall. And it also works when you have silicone oil in the vitreous cavity, because it avoids the coming to the anterior chamber.
I think we have many nice, interesting ways of doing acrobatics with IOLs these days. But I think what Wai-Ching did for this eye was probably the best surgery for this eye. And I think we're going to probably see more cases with capsular retention rings as patients all over the world gets older. There's more incidence of pseudoexfoliation dislocations where anterior segment surgeons tend to use more CTRs. And whenever during a surgery, if you don't know that there's a CTR beforehand and you encounter it, you're like, oh man, this is kind of suck now. And because we always struggle taking it out and trying to cut it, etc. It's really tough. So I think this is very elegant, and I think it's great that you knew beforehand that the eye had the CTR. And so when possible, I think it's great to have the op report from the previous surgery, if possible, just so you know what hardware you're dealing with.
Yeah. Thank you very much. André Jucá is asking, how did you keep the lens on the iris plane for suturing, Dr. Wade?
I used the retractor to hold it in place, and then I actually have my assistant keep that in position so that I can pass the Pauline needle through the capturing the haptic and the capsule retention ring, and using the 25 gauge needle to guide it through. So I was just holding it with the vitreous cutter.
Yeah, congratulations. It's not a simple thing to do. With a simple material, of course. Dr. Sadie is asking if the haptic is broken, would you perform this technique?
Well, first of all, if the haptic's broken, it may not be possible to do this properly, but if the bag, the capsular bag is still intact, then it is still possible, because you are anchoring the haptic and the bag together. So it is the capsular bag that actually holds things together. So I'm not sure what the question means. If it's a 3-piece IOL with the haptic broken, then no, it won't be possible. And this case particularly is possible to be sutured in places because the capsular bag is intact and it's a single-piece IOL. So so it is possible to suture it. But if you have a broken haptic in the 3-piece IOL, then I don't think it would be possible.
Okay, André Jucá is asking if you use the probe vacuum to hold it, or you just support it with the retractor? Yeah,
it just supported with retractor. It was you didn't see it. The IOL was actually swimming in the vitreous cavity, but once it was elevated, and you can just trap it with the cutter against the iris plane. It is not that challenging to do so, because with the capsule, the whole piece, the whole complex is actually a little bulky, and so you just need to gently lift it against the iris plane, and that's it.
Okay, Dr. Francini from Brazil, friend of ours, has a question for you.
Yeah, Dr. Len, congratulations for your surgery. Very beautiful, very elegant. And I would like to say, Vasco just said, but what I was point out is that a hashtag technique is very nice for this case that you show. And it's very safe too, because you can put all the bagular sac over the iris, and then you put the Prolene down it, and it's very stable. I've already done it. I've already done it as you showed here. It's very nice too. But sometimes when people don't have the security to do it and to put the Prolene at the side that the correct properly space, maybe sometimes it can be very how can I say, it can touch the iris, or it can touch the ciliary body and have some blooding, but it's a very elegant technique. Congratulations.
Well, thank you.
Thank you very much. Very interesting case. Now I'm gonna call Dr. Marcelo Murillo Sasamoto, our friend from Bolivia.
Okay.
Do you want to share your screen, Marcelo?
Yes. Let me see.
Thank you.
Okay, just let you know that we are working with an academic platform called Ophthalmology League in Latin America, with some other colleagues from Argentina and Uruguay.
Well, no Brazilians.
Can you see it?
Yeah, that is perfect.
Okay. So The name of the technique called Tetris technique, Tetris retinectomy technique. I usually perform before this combined large radial retinotomy with a circumferential retinectomy and the management of advanced proliferative retinopathy. This article was quite interesting, and since 2014, I started performing my surgeries, my PBR surgery with this technique. But nowadays, I call it this Tetris technique because we use almost the form of the Tetris play video game. And we start with this case. We have this pediatric retinal detachment, 10-year-old boy with all retinal detachment, inferior giant dialysis, and inferior PBR. Okay, so we start with the peritomy. See what's going on in the retina. As you can see the PBR. We're starting to working with the traction using triamcinolone also to better visualization. And the thing is, the form of the retinectomy, we are performing like the Tetris, no, almost like flex. Like a frayed form. And this helps us for sometimes to attach the retina, avoid complications in the future for reattachment. And it works well for me. Since 2018, I'm performing this type of procedure when it comes to retinectomy. And well, we finished this procedure with silicone oil. So I will show you the pre-op and post-op pictures. Those are the post-op, no, 1 month. And well, thank you.
Thank you very much, Dr. Sasamoto. Now, I would like to have a comment on this. Dr. Saad Wahib, do you want to comment this?
Sure. I mean, great surgery. Congratulations, Marcelio. I think, you know, doing retinectomies in these cases is sometimes essential to try to flatten the retina. But my question is, how long do you keep silicone, and have you had problems with hypotony in these cases postoperatively?
Yes, I want to comment also that we use a methotrexate every 15 days, no, to avoid retinal detachment. So hypotony, yes, is usually common, also neovascularization. But this specific case, I had like a 12 or 10 millimeters of mercury of pressure. But yes, it's commonly the hypotony, and sometimes you use corticosteroids or to maintain the aqueous humor with good levels. Yes, usually corticosteroids would be my answer.
Okay.
If I can comment, I think that was great surgery. That relaxing radial incision also disrupts the circumferential traction in addition to the radial traction that's relieved by regular retinectomies. And so I think the release of the tractional vectors in all directions, it's really cool. In this case, I think personally, in my hands, that would have been the second surgery that I do. And there was a lot of PVR, but I think a lot of children, especially with dialyses, they do really well with a primary buccal, even if there's PVR. Even if a buccal fails, I feel like you don't lose too much in terms of the PVR progressing too much. And so I think that's another consideration too. But I think you went all out, released all attraction, and that was really good surgery.
Thank you.
I also agree that it is a great quick surgery I've shown. And one thing that I like to share is that when I try to decide if I need to do a radial relaxing incisions, is I go to air, and under air you can see quite a bit of the residual traction that you may not have been able to see, because if you put the perforatum fluid, everything looks flat. But once you start taking out that heavy fluid, the persistent traction that you may not have been taken care of will show. And I found that under air, if you still have a persistent traction, radial incisions like you did helps to release that. And you can see that under air it will flatten, and that is quite reassuring. And you also know that you don't have to do excessive retinectomy if you don't have to. And so I too agree with Yoshihiro that the buccal could be useful. Although in a case of a giant hair, especially depending on if it's 180, then I don't use a buccal. If it's only 3 clock hour, then a buccal may be useful. And I tend to use a broader buccal because a narrow buccal can create fish mouth, and a wider surface will avoid that. And so selections of the proper size of the buccal will help to reduce the complications also. But well done.
Thank you. Excellent comment, doctor.
Thank you. Dr. André Jucá, do you want to comment on this case?
Sure. Congratulations. Excellent case, my friend. Do you use methotrexate as a routine in these severe PVR cases, or how do you use, who is going to go under methotrexate, and for how long time do you do it? Each 15 days for how much time? 3 months?
Yes.
Yeah.
We will start every 15 days. We start with 1200 micro, and then we change to 400 every month. So the first 3 months is every 15 days, and then we change every month for a 6-month period. So that's assuring sometimes that there's no a reattachment. So that's the principal problem in this retinal pediatric inflammation, and it's going well. I mean, since 2018, we are performing also using the methotrexate with good results. Not in all patients, but this complicated pediatric patient, yes, we're using in that form.
Oh, are you using for 6 months?
6
Even
months.
after silicone oil removal?
Then we perform the silicone oil, yes.
Okay. Thank you.
How do you give the methotrexate? Systemically or locally?
No, intravitreal.
Intravitreal. What's your dosage that you use for methotrexate intravitreal?
1,200 first at the beginning, and then 400 of maintenance.
Do you adjust the dose for silicone oil use because you already have silicone oil in the eye?
No. I mean, even though if the patient was without silicone oil, I would use the same dose.
Oh, okay. Because with the oil in the eye, the volume of distributions will be reduced. So toxicity is not a concern.
Yes.
So
the same problem happens with the use of anti-angiogenics and silicone oil. you know, I mean, the effect. So I used to perform, maintain the dose, and actually, I don't know what's the difference with the silicone oil.
I agree that the dosing will be very different because of just the very thin aqueous layer between the oil and the retina. And however, the idea of maintaining the same concentration was from the methotrexate treatments for lymphoma cases, and where people just did the same 400 milligrams, which worked really great. And that's what we're doing also for the Aldera Therapeutics clinical trial, just maintaining the similar dose. But I have to say, kids in Bolivia are very brave. I don't know how many kids in the United States who are 10 years old can tolerate these regular intravitreal injections. Kudos to your patients.
True.
Yeah. Thank you very much for the case, Dr. Sasamoto, and thank you for the comments. Now, André Jucá, do you want to share your screen, or do you want us to play your video?
I have your video ready here, but if you want, if you want to share, it's up to you.
You're muted, André.
Okay, go ahead, my friend. You can share it.
I will share it.
So I brought two cases, one of complicated, two cases we got complication with buccal surgery. One was 10 years later, and the other one was just during the surgery. So we bought this because we do a lot of buccal still, and we don't see a lot of in meetings. And this woman had a retinal detachment 10 years before, and she was complaining of a lot of pain. We didn't see anything, but anyway, so we decided to remove because she could not take his life normally because of the pain. The retina was okay. This was 10 years later. We didn't see any sign of infection or something like that. But when we decided to remove the buccal, we realized that we have this opening in the sclera. It was a big hole on the sclera, and we just cut it out. And then we just decided to suture it because we did not have a scleral patch or something like that. It was just an unpredictable situation. And we just suture it, and we put gas on the eye to keep it formed, because even with suture, the eye was very soft. So in the end, we just inserted gas, and it was quite amazing to have this situation because the eye was like 20/25, very good vision, and then we have this in post-op, and then we just think, well, what was going on? And then we realized, please go back a little bit, Hudson, just one slide, please go back. Yeah. And then we realized that there was a hole, and okay, stop there. You see here, there is a hole in the center of this darker part that we just missed it. And this, there was a scleral necrosis, and that's why the patient had so much pain. This was 10 years after. So the retina was fine, but she couldn't bear the pain, and we decided to remove it. And when we removed it, there was this big hole on the sclera. So it was kind of a surprise. And when we went to study the case, what did we miss? And there was this sign here in the center that now we are very paying attention to this kind of sign in this situation. So this is the trick, okay? Okay, if anyone wants to comment on or share if they have cases like that.
Yeah, thank you very much. Very good case, Dr. Jucá. Dr. Yoshihiro, do you want to comment on this one?
Oh, I was just commenting on the chat function here that it's very unusual. you can see this with Miragel buckles, where sometimes you can have internal erosion, but it seems like you just had a regular silicone band that was not Miragel, right?
Right, yes.
Very unusual.
That was just a standard buckle with a band, 240 band, and I think it was 7 buckle or something like that.
Yeah,
it was unusual.
I know it's very unusual because I also do a lot of buckle and sometimes we keep removing. But how long was the pain before?
I tried to manage it for months, like 3 months. Then she was very tired and I was very tired and I decided to remove it.
I understand. Yeah, I think so. Sometimes I think better to remove earlier so that this necrosis may not have, but very difficult to say. I think this one couldn't tell till the last that there is a necrosis and I have a hole in the sclera. But I think this is what I keep telling the patient. Removing buckle is not simple. You have to, there's the risk of many things and we have to take care and then do the surgery. Good.
Yeah, but everything was so fine that, the retina is so good, the vision is so good, it's not going to touch it. Just try something to keep the pain okay. And I was not sure that was it. But in the end was that. I didn't understand why there was so much pain. And the reason was this scleral rupture, this scleral necrosis.
Yeah, just want to make a comment that there's a lot of cryo in the area of the tear. And if you do cryo, I wouldn't say excessive, you do a lot of cryo, you do cause some damage to the sclera. And if there are already pre-existing thinning in that area, so you can potentially set up for necrosis later on. And in the area where the buckle is pressing against it, you have a double whammy. So you damaged the tissue with the cryo and you have pressure applied with the a very kind of firm and high buckle. And then that combination may be part of the reason that could happen.
Yeah, I think you are right. I think this was the mechanism that did happen. And the sign that I missed was this dark area in the center. This in this area, you have no sclera, just tendon and conjunctiva blocking everything. So the eye was not hypotonous, The eye was in normal pressure situation. So, but this dark area in the center should be a sign to pay attention that this may have ruptured the globe. So you may prepare better than I did using a scleral patch to cover it instead of suturing. Although the suturing, it just worked.
Yeah, you did very well. A lot of people would have panicked. I would have been panicked looking at that.
I was panicked.
You done very good surgery there, beautifully repaired.
Thank you. Next, okay.
Did the pain resolve?
Yeah, the pain resolved.
Yeah, so that's great.
Yeah, in the end. But this next case was inferior detachment. There was this small hole here in this lattice, and it was a young myop, and we decided to go to buccal surgery because she was like 20 or something. And we did put the buccal. We do in this case buccal with endo laser after external drainage, and we do not use cryo anymore. Not because of the last case, but we are moving to do laser. But when we're doing the laser, we saw something was going out, and the patient was just under. Please come back a little bit, Hudson. The patient was under, stop there. No, a little bit more. Okay, a little bit more. I just want to show the flap. The patient had LASIK. And come back more. No, just to the external surgery. Hudson, come back. Yeah, stop there. This is the flap that moved out. So we're not sure, and we asked the patient, did you get LASIK surgery? And the patient said, yeah, I did get LASIK. And that's it. There was the flap that dislocated during the surgery. So you do not, the trick here is you do not bother trying to put it back because we're not going to get it until the end of the surgery. You just move it away, put some gel over the stroma of the cornea and just go ahead. And at the end of the surgery, you put the flap back and put some contact lens and it will work just fine. So we did move the flap out of the way, put some gel, and just, you see, you just did the surgery because the flap just dislocated, okay? Okay. You can go ahead to play the video, please. Okay. So you just move it, you just put some gel, you just do the laser, and the laser with the illuminated probe. And then I just like to suture anyway. And then you suture the contour, and then you just put back the flap is okay. Okay, that's it. That's just another unusual situation, but we are seeing more and more of these patients that have gone under LASIK and just put the contact lens to protect it. That's, and this is the post-op. So the trick was just to do not bother with the flap, just put it away and it will work just fine. Anyone has had this kind of complication during?
The only thing is I have done it, but luckily I didn't face the complication. But in case you knew the patient had LASIK done, would you have done anything different?
Well, I'm not sure. Maybe I would be more careful wetting the cornea.
Okay.
Perhaps using gel before to avoid it. You know, when you do the maneuvers, moving around, and it's really, and this patient had LASIK like 3 or 4 years before. It was not recent.
No, sure. I think you managed it very well. And I have done with the post-LASIK buckle. But I think every time I use the skip and retractor and say that the cornea has covered well and then turn the eyes carefully. And I keep telling the thing, don't make a tug of war with the pulling the muscles. So I agree. I think, and then you have to have a speculum which does not have any sharp edge so that when you turn, that doesn't hit.
Yeah, yeah, good.
Thank you. Dr. Rodrigo Pegado, do you have a comment on this one?
I think he didn't hear. Rodrigo Pegado, can you hear us?
I think he's...
I'm asking him to unmute.
I had a question.
I think he lost connection.
Rodrigo, can you hear?
Yeah, it's better now.
Okay.
Do you have a comment on this case from Dr. André Jucá?
André, you use the 27 gauge in your surgeries now?
Yeah, I do use, but in this case, I use the 25 gauge. I like the 25 gauge because it has illumination on it. So I do not have a 27 gauge probe that has an illumination on it. So I like to use just one and then do the job. So it was a 25 gauge probe, but there was just one sclerotomy.
Okay. Dr. Sethi, do you want to comment on this one?
I just had a question for the first case, Dr. Andre, very nice, unusual cases that you're showing. In the first case, would you think it be possible to have harvested a partial thickness scleral flap in the same eye and then close that defect, like we make a tunnel, and then you just leave that, take that partial flap in case we can't suture it?
Yeah, I would do a scleral patch, but I was not prepared. It was a kind of a surprise. So I have to do what I got on that instant. So we do have a lot of scleral patch, but in that situation, I was not looking for it, and it's just something that happened. What the trick there was just to really find out what's going on with the patient, because pain is a very subjective feeling, and at first we do not really believe the patient because the eye was quiet, there was no inflammation, no secretion. It was many years ago, 10 years ago. So we just do not believe really the patient. The vision was good, and there was this pain that the patient keep coming back. But there was a sign that I missed, was that dark spot in the center of the whitish area. And I do believe that the creel was a little heavy, and this may have caused this late scleral necrosis. And the pressure of the eye was normal. The eye was not hypotense. That would be an evident sign of rupture of the globe. So it was difficult to see, but there was a sign. Now I learned, and I would like to share that.
Okay, thank you very much, Dr. Jucá. So, Dr. Rodrigo Pegado, we shall move forward to our case.
Okay, thank you. Thank you very much, Rafael. First, I'd like to thank the organizer, Dr. Hudson Nakamura, and moderator, Rafael Arantes. I'm from the small city, and the small city near to Rio de Janeiro in Brazil. In this case, we did a Paris plan vitrectomy in the eyes with a PPV. Can you play, please?
Okay, Hudson, can you play?
I work together with my partner Luis Gustavo in Niterói. You don't have the sound. Hudson, it's better I share. May I share?
Yeah, you can share it.
Thank you. The sound is better with the music and then.
You did this case in Rio?
We cannot hear the volume because you're using a earphone. Okay. We cannot hear the case. Okay. Because
Okay.
The airport.
No problem. No. Okay, no problem. Just a minute. The patient had retinal traction redetachment. He also had proliferative vitreoretinopathy, previously combined cataract and PPV for TRD, silicone oil, 4 months ago. The pupil was dilated. After removing the oil vitrectomy, we performed membranectomy. We also did first macular peeling. And then retina got all tractions.
Did you use the cautery?
Yeah. Let's cut the video. And after removing the traction with the rent piece and cutting them, we on the laser performance.
They are doing PRP now.
Yeah. There was no need for silicone oil. We inserted the intraocular gas. The retina remained attached. And then operates the fluid in the glaucoma for my kids.
Okay, thank you very much, Dr. Rodrigo. I would like to ask Dr. Hudson, do you want to comment on this case?
Me?
Yeah.
Oh yeah, Rodrigo, great case. And you did not use silicone oil, and I saw some pre-retinal hemorrhages, but I think they were just not, you didn't have any bleeding, so that was okay without silicone oil, okay? And you did the good retinotomies and performed the cautery. So the different thing I would do a little more endocautery, because during these hemorrhages, during the case, the media gets very hazy. So I like doing endocautery for most of the cases. And then I'm really confident that I won't have any problem leaving the air with gas. Otherwise, I would use silicone oil. But the case was great, really very good performance.
Yeah, you use the gas. We prepare the patients in filter to operate the glaucoma, maybe. And then we remember 25% of diabetics-related visual loss stems from complications. And then we need to operate faster the patients, the case.
Okay, thank you very much. Now, Hudson, do you want to share your video?
Yeah, I was the last trauma case that we saw. I have a case very interesting on trauma that I did not use the magnet. This was really challenging. I will share it in just a moment. We had this intraocular gunshot injury, intraocular foreign body. You have the lesion there, a vertical one, and the two foreign bodies inside the eye, one in the mid-vitreous and another one stuck at the retinal periphery, stuck on the choroid. And did the ultrasound, and you can actually see hyperreflectivity with the two intraocular foreign bodies. The rexes were so tough, everything was adherent, and we had this vitreous, the anterior chamber. We had to go ahead with the vitrectomy, and that's where the intraocular foreign body was sitting, one of them. You see the intraocular foreign body. The media was a little hazy, but we could still grab the intraocular foreign body without any problem, without using PFC, and removing it without a magnet. This one was a small one. So, but the second one, take a look. I saw the intraocular foreign body. I just picked on the foreign body itself. I did not was hard on the choroid, nor even the retina. And then I removed it. But then when I went back to the retina at the periphery was detached because of the intraocular foreign body. Then we used PFO to attach the retina, do the appropriate endo laser. As you see here, the endo laser and the retina got fully attached with no slippage. And after that, that laser, I did a direct exchange, as we were commenting with Dr. Diveni. This exchange direct, we don't have any slippage. I did the endo laser in the far periphery under silicone oil. And this is the post-operative period. And the patient is cool. The case is great, and the retina is attached so far. And we are trying to plan for the silicone oil removal, not now. The surgery was 2 months ago. And I presented the surgery into iTube, and the iTube people asked me to invite you to share your videos there. It's pretty easy. You just have to share a video and comment, and narrow down the video to maybe 3 minutes and something. And they're gonna accept your video if it's good. And they asked me to share this information with you as well.
Okay, thank you very much, Hudson. Dr. Wei-Ching Lam, do you want to comment on this video, this case, sorry?
Yes, I'd like to congratulate Hudson for doing such a beautiful surgery these days. And managing foreign body is not always easy. And especially as he has shown that surprises can come up. Once you take out the foreign body, you may have a retinal detachment to fix, and you may even have a double perforations because of the depth of the penetrations of the foreign body. I think it is always an advantageous to be able to do both the anterior segment and posterior segment surgery, and he showed the approach that he did phaco first, and then deal with the posterior segment injury. In North America,
the Rexis was very tough, and we know in advance that the capsule was ruptured, so we didn't have any choice as to remove the lens by lensectomy. But the lens was not so hard, you know. The lens was kind of fluffy. And then we went ahead with the vitrectomy to prepare for futurely secondary implant, because the macula is okay, and I think this guy has a good outcome.
Yeah, no, it's quick. It's very well done, and congratulations.
This was really tough. This was really challenging. My last case, Yoshihiro, was a macula hole. You know, this decision, the tough decision, the challenging decision from the last case, Retinawesome 2, was to decide what to do. But this one, I had no choice. I had to go ahead and remove the intraocular foreign bodies. And one thing interesting, I was searching for another third intraocular foreign body, but there were only 2. But then I was searching, and then I found the infusion line. I found the wire, the metal thing from the infusion line, and I thought it would be but we have to search, all the time. Otherwise, if we leave, as you were commenting in the previous cases, if we leave the intraocular foreign body there and we get siderosis and other complications, the case is lost.
Yeah, your pre-op assessment helps like you did a CT, and you also do an ultrasound, and that should help you to determine the locations and the number of foreign body that you need to take care of. So you're absolutely right. I think time spent both preoperatively and in particularly to making sure you account for all the foreign body that you have to be dealing with intraoperatively.
Mm-hmm.
Thank you very much. Dr. Sethi, do you want to comment on this?
I think a very well managed case, and I just want to ask, Dr. Hudson, did you do an ILM peeling as well in this case? And what is your take on the ILM peeling in trauma cases?
No, I did not do ILM peeling for this case because the macula was cool, was normal, but there were the vitreous, the hyaloid, this posterior hyaloid at the beginning of the case was so adherent, was so difficult to remove it. I had to cut with the cutter flush to the retina without reaching the retina, but it was tough. I had to, you know, the vitrectomy took about 20, 25 minutes to remove all the vitreous because it was very adherent. But I didn't do any peel because the macula was clear and I did not see any reason for doing that.
Great case. Can I have a quick question? Is it possible?
Yeah, of course.
Sure. Great case, Hudson. I was just wondering, what do you feel about using PFC in these cases? And the idea of protecting the macula when you're dealing with these foreign bodies. And the other thing is that what I've noticed personally is when you have these foreign bodies impacted, I like to leave the removal of the foreign body to the end. So I want to make sure I remove all the vitreous because I'm worried if I go behind after the foreign body first, you get double perforation and you get fluids going into the orbit and then it becomes a mess. So I don't know how the panel or how do you feel about this?
I feel that this surgery, you know, after we remove the vitreous, one of the intraocular foreign bodies that we diagnosed and via ultrasound and CT, it was just floating on the vitreous and was sitting on the retina. So I thought it was so easy to use the macular lens to have a good view very close to the intraocular foreign body, and I used this crocodile forceps just like that, and I had very good 3D. So I didn't feel like having to use PFC to protect anything because it was easy to catch it, as you saw in the video, and I just remove it, and I took it in the forceps and just took it out of the eye, and this was this smaller intraocular foreign body. The other one that was stuck in the very periphery, the reason I didn't use it, I don't think I would have to use the magnet, is that I used a very peripheral wide-angle lens, and so I saw it, and I went straight to the foreign body with the same forceps, the crocodile, and then I grab it and I just remove it. So I did not cause any trauma. The trauma that I think I caused at the end of the case was trying to search for another intraocular foreign body, going after the very periphery, because I had to do that. Otherwise, if I left any foreign body, maybe the case would be finished, you know, within time and siderosis. And then I was trying to find it, and I found the infusion line, but no problem. Then the periphery, I just did the PFC, did the barrier laser that worked very well, and direct for the exchange, ended with the laser around the hole.
And no, the question to the answer to Dr. Saad Wahib is that double perforation, I think, so fortunately, the patient takes few days to come. And by the time there is some healing happens, so I think the fluid doesn't go through the perforation because I have removed pellets, or pellets have gone through the vitreous retina and choroid and into the orbit, but nothing happens. Only thing I toilet the wound and I don't enter there, but I think I treat it like a coloboma choroid in the place where the exit wound is there. And in Hudson's case, also a beautiful case where you remove, I think usually fluid doesn't go through that. And I think only when the foreign body is in the vitreous, I usually remove it before completing the vitrectomy so that I don't want the foreign body to fall down on retina. But if it is impacted, like the Hudson's case, I remove it and I don't think anything. Only thing I do a endo laser around it and then remove it so that if there's some hemorrhage happens, you already have done a laser and the hemorrhage will clear.
Yeah, and the patient is happy. You know, we're just waiting for his own corticoids, but the eye is calm. No inflammation now, and we're just waiting for about 3 or 4 months to remove the silicone oil, or maybe not, or maybe implant the lens, the intraocular lens without removing the silicone oil. But if it gets good enough, and I would probably remove and implant the IOL right away.
Yeah, yes. Wonderful, Hudson. Really great case.
Thank you, thank you.
Okay, so now we are closing the event now, and I would like to thank you all the participants due to the high level of the cases presented. We expect you all at the next event of Retinawesome, And if you have any consideration, mic is open for you.
Yeah, no, I just wanted to invite everybody as a part of our Ocular Trauma Society of India. We are celebrating Silver Jubilee and we are doing a first video festival on ocular trauma. We have Hudson as our keynote speaker tomorrow. It's at 7 p.m. India time. It is the OTSI. It will be there in the YouTube, and I'm sure Hudson will put it in the group. And hope whoever has time, because I know today you had a long session. Me and Hudson will be there again for a long session tomorrow. But tomorrow is exclusive trauma. And thank you very much, Hudson. And I'm part of your Retinawesome, and thanks for you to be part of our Ocular Trauma Society of India.
Yeah, thank you for inviting me. And Dr. Castellanos, I was also apologize for not being here. She had this problem, this issue with the video. But we know about Dr. Luca Michev's father, and you know, he passed away 2 days ago. But I'm very happy to be with you, and thank you, Dr. Diveni, my professor, Dr. Lam, Wahib Shad, my partner, and Yoshihiro, and everybody, Vasco Bravo, Drejuka. And the important thing is, I have to say here, the important person here is Rafael Arantes. You know, I got disconnected here for a while due to internet issues, but you know, the difference is made when we have a good moderator. And I have to thank you, Dr. Rafael Arantes, for being such a good doctor and such a good moderator. And this session was pretty good. Thank you very much.
It's my pleasure. No need for anything.
Yes.
So I think we are closing here. Bye-bye, everyone. See you
Bye.
next event. See you later.
Bye. Have a great day.
Great.
Bye-bye. Bye-bye. What happened?
Bye. Yes.
Rodrigo, nice case.
Yes.
Congratulations.
Thank you, Hudson. And we will see you tomorrow. And tomorrow we are going to have the Zoom open an hour before, whenever you want.
Did you get to know why have Natarajan?
Pardon?
Do you live close? Do you work close? I mean, the same city?
No, he's in Delhi. Vaibhav Sethi is in Delhi. And I know his father, his mother, and also the grandfather.
Yeah, that's great.
And also the whole family, rather.
I know.
I was there since last year. Spent a day.
Family with lots of quality and plays great music as well, you know?
Yes. Yes.
Very good case, Dr. I did not share your case because my internet, I don't know why. This is a very good internet connection here, but you know, the moderator was great doing his job.
Right. Yes, yes.
Thank you.
Thank you. Very good, Vaibhav. Nice to see you.
Nice to see you. Have a good night.
Good night, yes. And have a nice day. See you tomorrow.
Bye-bye.
See you tomorrow.